Good morning, everybody. My name is Viwathana Tomket. I'm from Prince of Songkhla University. Songkhla is the name of my province. And I'm also the member of the Royal College of Radiologists of Thailand. I'm the former president of the college, and also the committee of the Asian Society of Thoracic Radiology, and the committee of the Asian Oceanian Society of Radiology. So on behalf of AOSI, I would like to thank the Vietnamese Society for this invitation, and we have activity together. Before I start my speech, I would like to declare no conflict of interest of my lecture. I am a government officer, and I receive no sponsorship or grant from any industries. My contents will speak only pulmonary tuberculosis. I will not give a talk on other organs in the thorax, because pulmonary tuberculosis is the most common form of tuberculosis. I would like to review microscopic anatomy and histology, and also the CT findings for better understanding, and then you can apply it easier. And one of the best articles of tuberculosis is around 30 years ago from Japanese and Korean radiologists, and two of them are Professor Im and Professor Ito, and I know these two great radiologists very well. And this is a photo of Professor Harumi Ito from Japan and Professor Jung-ji Im from Korea. So if you read articles about pulmonary tuberculosis, it's very difficult to avoid these two famous lecturers. So from that article, we can group the findings, the CT findings, into four groups, 4 stages. Number one is the centilobular nodules, is the earliest stage of the disease, and then when the disease progresses, you can see the bronchocentric consolidation is a triangular or wedge-shaped consolidation surrounding the disease bronchiole. And after that, it will advance into granulomatous process. So the fibrosis in granulomatous process will retract the lesion from triangular wedge-shape into the round. It will be more round and have the spiculated nodules. And also it will cause the rupture of the central bronchus, so you can see the central cavity within the lesion. And the final stage is the fibrosis only, is the stricture of the bronchus. This is the permanent damage, so no recovery of this stage. So I would like to start with the first stage, is centilobular nodules. So I would like to touch the basic histology of the bronchiole. At the area of terminal bronchiole, this is the place where the inhaled gas reduce the velocity into zero for suitable air for the gas exchange. So at the velocity, zero velocity is a good place for the inhaled dust and germs to be sediments and deposited into the walls. So this area is the origin of the inhalation, all kinds of inhalation disease, whether it is tuberculosis, bronchopneumonia, or pneumoconiosis, or COPD. So this is the point, this is the original point of the inhalation disease. On CT, you can see the centilobular nodules. I think all of us know centilobular nodule very well. And one of the famous words is the 3-in-1 pattern. And this word, I think, is from Professor Jung-ji Im and Professor Ito. This is the radiographs of the histology. You can see the centilobular nodules, but we can see centilobular nodule in bronchopneumonia too. They are very similar. This is centilobular nodules in tuberculosis, and this is in bronchopneumonia. It's very, very similar because the process is exactly the same. However, Professor Ito may observe that the centilobular nodules are denser, better defined, and sometimes the disease can extend into the alveolar ducts, very close to the pleura. So it can appear like a polylymphatic nodules, but in fact they are not. They are centilobular nodules, but can go deeper, close to the pleura. This is the three findings of tuberculosis comparing to sentinel nodules of bronchopneumonias. So they are very, very similar, but you may find that the sentinel nodules in tuberculosis are better defined. They are denser and closer to the pleura. And in bronchopneumonia, they are a little bit poorly defined. And around 2015, there was an article from Korean doctors saying about polylymphatic spreading. However, 2 years after this article published, Professor Ito and Professor Im re-examined their histology specimens and found that there is no polylymphatic spreading. So, polylymphatic spreading in tuberculosis is still in question. The second stage is the bronchocentric consolidation. You can see the wedge-shaped opacity or consolidation. The base is point to the pleura and the apex point to the hilum. And if the lesion turn to be the stage 3, you can see the central cavity. And you can also see the lesion at the stage 1, sentinel nodules surrounding the consolidation. So this is the stage 1 and stage 2. And stage 3 is the granulomatous process. You can see that the lesion become more round, not wedge-shaped as stage 2, and you can see central cavity because of the bronchial rupture. And also you can observe the sentinel nodules of the stage 1 in the same patient in the same area. If we have a chance to do the contrast examination, you can see that the material of the stage 3 are not enhanced because it's caseous necrosis, so it's a vascular component. And if you test the central cavity, you may observe that the cavity connect to the bronchiole, so this is a bronchial rupture. And the rim is smoothly thin, and you can observe the rim enhancement in contrast to lung cancer, which the rim is more irregular and more enhancing. And the last one is the bronchial stricture. This is the radiograph of the histology. You can see complete obstruction of the bronchiole, and the surrounding lung become hypoattenuated because of the air retention. So this is a permanent damage, even though the disease is completely treated, but this permanent damage will remain with the patient until the last day of their life. This is the CTs and radiograph of histology from Professor Im. You can see at the first stage or second stage, you can see sentinel nodules, though this is quite active. And after the treatment, the sentinel nodules disappear, but remain some area of the air trapping, wedge-shaped area of air trapping, and the histology show complete obliteration. This histology, radiograph of histology is from this area in the same patient. So this can explain that why the tuberculosis patient, even though we treat them very well and complete, but the patients can still have the symptom of dyspnea on exercise. Similar thing happened to my patients also. My patients have been treated as tuberculosis because of sentinel nodules in superior segment of both lungs, more on the left side. But after the treatment, 5 months after, you can see that sentinel nodules completely disappear, but the remaining, the lung at that area has sign of the air retention because of the complete obliteration of the bronchus. And we can see the area of air trapping better if we ask the patient to exhale. For example, this is inhalation. We can observe the area of more hypodensity, but when the patient exhales, we can see clearly better. And this is inspiration and expiration. You can see the air trapping very well here. So the typical finding is like a fibrosis. You can see the bronchovascular bundles are pulled together. And also the area of expansion because of air trapping. So fibrosis together with lung expansion are typical findings of post-tuberculosis. This is the same. And TB tend to happen at the areas of low lymphatic flows. it happened to be the upper lobe because lymphatic flow is better in the lower lungs and poor in the upper lungs. In the sagittal images, you can see the TB involved the apical and posterior segment of the upper lobe and superior segment of the lower lobe. So this area is the area of low lymphatic flow. So that's why tuberculosis remains in this area. Tuberculosis tend to repeat the findings. I think all of us are very familiar to tuberculosis on chest X-ray. For example, this patient, 80 years old patient, has a chronic infiltration in the upper lobe, and the right lung seems smaller than the left lung. So in the chest conference, this patient, all the radiologists and chest medicine doctor, all of us thought of tuberculosis because of the typical chest X-ray. However, the patient has been treated with tuberculosis, but the symptoms still persist. So we did CT. And CT showed the traction bronchitis in the right upper lobe. However, there are some area of the ground gas opacity and also the traction bronchitis in both lungs. And when we observe closely, you can see the ground gas opacity near the pleura and around the bronchus. And you can see the lesions are very uniform in appearance and also uniform in distribution too. So this is not tuberculosis because tuberculosis usually are of different ages and have not uniform distribution. And at the area of traction bronchitis, you can observe the ground gas opacity, which could be responsible for the traction bronchitis. For example, this, so we call bronchocentric ground gas opacity. So this is not tuberculosis, this is ILD. And then we send the patient to have further investigation about autoimmune. So it proved to be the IPAF. Interstitial pneumonia with autoimmune feature. Another good example is this young gentleman. He came to the hospital because of the chronic nodular infiltration in the upper lobe. And he has been treated as tuberculosis from other hospitals for 2 years already. But the symptom still persist. You may observe that in the upper lung there are nodular infiltration, but in the lower lung you can see the linear infiltration. So as we call curly lines. So upper nodular and lower linear in this patient. And also the widening of the superior mediastinum, but the doctor from the other hospital thought that this is mediastinal lymphadenopathy. And the CT showed the nodules in the upper lung tend to around the bronchovascular structures and also the subpleural. So it has a dominant feature around central structure and also the subpleural. So this is polylymphatic spreading of the nodules. This is not typical of tuberculosis, as I mentioned before. And in the lower lung, in the lower lung CT nicely showed the smooth interlobular septal thickening. This is not the tuberculosis also, because tuberculosis will appear at the upper lung, no involvement in the lower lung, and smooth interlobular septum is not the finding of tuberculosis. And comparing to mediastinum window, you can see that in the nodular upper lung is also the mediastinal lymphadenopathy. So this is sarcoidosis, because polylymphatic nodules are common in 3 diseases. One is sarcoidosis, and second is the silicosis, and the third one is the lymphangitis metastasis. But the patient is very young, so we think about silicosis or sarcoidosis, but the patient has no history of the dust exposure. And in the lower lung, the smooth septal thickening, in the miasm you can see the enlargement of the left atrium and heavily calcified mitral valve. So this is the venous congestion, venous and lymphatic congestion from mitral valvular stenosis. So after, and this CT, we took only maybe 1 minute. 1 minute for the examination. We asked the patient to control the breathing only 5 seconds. So within 5 seconds, we can solve these complicated findings in this patient. And after the treatment, you can see that all infiltration disappear. And you can see the prosthetic mitral valve and also aortic valve in this patient. And then the patient can return to his healthy condition. Okay, I talk about pulmonary tuberculosis because number one, in the future, we will have more and more CT because now all hospitals have CT and we do more cases of screening lung cancer. And Vietnam and Thailand, we still have tuberculosis. We can see tuberculosis more and more in the future. So before ending my talk, I would like to summarize again about the pulmonary tuberculosis. It should be non-uniform in appearance and distribution. And I have reviewed the macroscopic anatomy and histology together with 3D findings for better understanding, and we group the disease into 4 stages. Thank you very much.